Okay, hello. Good afternoon, everyone. I was asked to discuss HIV and hepatitis, specifically focus on Hep B and Hep C in the context of HIV. So here are my disclosures. Objectives for this talk is to discuss hepatitis B and hepatitis C, a little bit on local epidemiology, we're going to discuss a little bit on natural history, serology and testing basics, prevention for hepatitis B, managing Hep B and Hep C in the co-infected population, specifically in people living with HIV, and non-pharmacologic advice. So in terms of death from viral hepatitis, as opposed to other heavy burden infectious diseases, it's been known that in the past decade, viral hepatitis has been increasing in terms of mortality. The morbidity and mortality from viral hepatitis has still been increasing in spite of the world getting better at managing TB, malaria, and the rest of the world managing HIV better. So this is the global health sector strategy for viral hepatitis. It was created for 2016 to 2021, and the ambitious goal is for us to eliminate viral hepatitis as a major public health threat by the year 2030, meaning decrease new infection by 90% and decrease by 65% the number of people dying from viral hepatitis. As a response to this, in 2017, the Department of Health created this comprehensive national program for viral hepatitis, and this may be of interest to you, specifically because it's still under the NAS-PCP, or the same program and department that manages HIV/AIDS and STI prevention and control. So what's the more commonly, we know what acute and chronic is. Most of our patients want to ask us, acute ba ako, doc, or chronic, no? So in this case, we see that acute versus chronic in viral infection, hepatitis B and C are the only known viral hepatitis that cause chronic infection. And when you say acute, it's what happens shortly after you get exposed and you get the infection. The thing is, it can still resolve. So there's a chance within the first 6 months of infection that your immune system will work and you will clear the infection spontaneously. While a chronic infection is one that is long-term, lasting more than 6 months. And it's important because it's with these cases that you get complications. So when you have prolonged or chronic Hep B or Hep C hepatitis, this can lead to liver cirrhosis, and this is fertile ground for hepatocellular carcinoma or primary liver cancer. But the unique thing about chronic Hep B or Hep C, even just with the chronic hepatitis, and even if you don't get cirrhosis yet, you may jump to getting hepatocellular cancer, especially in the case of hepatitis B. So let's start with hepatitis B basics and maybe discuss it in the context of HIV. So this is the burden of hepatitis B in the Philippines. This is a Lancet study published in 2018. We're part of the top 10 countries that produce majority of Hep B positivity in the world. In fact, we're number 5 with an estimated 10 million patients with hepatitis B. And we seem to know that we're still going to have a persistent problem over the next few decades because we're also 7th in the world in terms of the number of 5-year-olds with hepatitis B. So in a DOST and PCHRD sponsored NIH study of Dr. Ong and others in 2017, based on a modeling study, the estimated prevalence in the general population of hepatitis B is about 10 million also, or 9.7%. And if you look at the graph here, the peak incidence is found in the functional population, 30 to 34. So how can one get hepatitis B? Similar to HIV, it's also transmitted through blood and body fluid contact. It can be gotten from direct contact with infected body fluid and blood. I encircled specifically maternal to child transmission because in endemic countries or high-risk countries like the Philippines, maternal to child infection is the most common cause of transmission. But this may be pertinent in our persons living with HIV. You can also get it through sharing of contaminated needles, sharing of toothbrushes, razors, nail clippers, manicure, pedicure essentials, exposure from needle sticks or contaminated sharp instruments, contact with open wounds, and of course, unprotected high-risk sex with an infected partner. After infection, not everyone becomes a chronic hepatitis B patient. And this will depend largely on what age you were at the time you were exposed or infected by the virus. The younger age you are at infection, the higher risk of becoming a chronic carrier. So 90% of infected infants with hepatitis B will become chronic or carry the virus for lifelong, while it drops drastically at years 1 to 5 years of age to 25 to 50%, whereas majority of adults who get infected or exposed to hepatitis B will be able to clear the virus spontaneously without treatment. The other thing is, if you get hepatitis B or acute hepatitis B at a younger age, there is less risk of being symptomatic in the initial phase, meaning you don't get the classically known hepatitis symptoms of fever, jaundice, yung paninilaw, or abdominal pain. You may be asymptomatic but get the infection. So how do we diagnose hepatitis B? As Dr. Kate said, very simple, with the S antigen test. If it's positive, then one has active hepatitis B at the moment. This is the rest of the Hep B profile, very expensive if done by the patient in full. So briefly, S antigen is the hallmark of infection. If this is positive, the HBsAg is positive or reactive, then you have either acute or chronic Hep B. Anti-HB core antibody, IgM, can be positive in acute infection or when you get severe flares of chronic infection, meaning you have chronic hepatitis B and then suddenly your DNA or the viral load goes up. This can lead to a positivity of your anti-HBc IgM. While your anti-HB core total is the most constant marker of infection, meaning it will be positive in resolved or past infection or even in current infection. E antigen, HBeAg, is positive in patients with high viral load of hepatitis B and those who are more infectious, while the positivity, the seroconversion from E antigen positive to anti-HBe usually indicates better immune control and decreasing viral load of your Hep B. Your protective antibody or anti-HBs, if positive, may indicate immunity from a prior vaccination or recovery from a previous infection. But what's the basic Hep B profile picture? If possible, you should get at least these three things: HBsAg, anti-HB core total or anti-HBc IgG, and anti-HBs. So HBs antigen, because of course it tests for current carriage of the virus. Anti-HB core total or IgG will be positive in past or current hepatitis B, while anti-HBs is important because it tests for immunity. So we'll cover this when we return to the theoretical cases discussed by Dr. K. So this is a summary of how we interpret hepatitis B serology. If your S antigen, all of your serologic patterns are negative, then it means that you were never exposed. If your anti-HB core, IgG or total and antibody is positive, then it means you've had a past infection. If you have total anti-HB core positive, then it means this may mean a past natural infection wherein your antibody has cleared over time, or it may mean that you have an occult infection. Your S antigen is very low and only your anti-HBc is detected. If everything is negative apart from your anti-HBs, this means you're immune due to vaccination. If everything, your anti-HBc, anti-HBc IgM is positive, but your anti-HBs is already positive, this may mean you've recovered from a recent infection. If you have a positive S antigen, you may have chronic hepatitis B, if this is proved to be positive for more than 6 months, or sometimes in acute infection, a clue is your IgM anti-HB core is positive, together with your HBsAg and your total anti-HPC. So how do we prevent hepatitis B? Very important in our patients. Because hepatitis B, as you well know, has a vaccine. In the Philippines, there is a law that all infants should be given the first dose of their hepatitis B vaccine within the 24 hours of birth, and get the rest of the vaccination together with the pentavalent vaccine of the EPI before they reach 1 year of age. And this is free under the program of the Department of Health. So if a patient has no prior HBV or hepatitis B exposure, and how do you find this out? If negative siya sa S antigen, anti-HBs is also negative, anti-HB core is also negative, then we vaccinate versus hepatitis B using the Hep B vaccine. Ideally, we give this before the CD4 count declines to below 350, and that's because the chance that you will mount an antibody response is higher with a CD4 count of more than 350, but this should not hinder vaccination of all patients with HIV, because some patients will develop the antibody even if their CD4 count is less than 200. So in short, vaccinate everyone with HIV against hepatitis B. The schedule of vaccination is similar to other adults. The recommended schedule is 3 doses, with the second dose being 1 month after the first dose, and the last and third dose being 6 months after the first dose. The dose is 20 micrograms per ml. And then there is some will double the dose in the hopes of increasing the chance of them developing the antibody, but standard is still to use 20 micrograms ml per dose. The important thing is you should check if vaccination worked after 1 to 2 months after the last dose of the vaccine. And it's been said that if you seroconvert, meaning your anti-HBs becomes more than 10 milli-IU per ml, then that means you've created immunity. If it doesn't work, the recommendation is to repeat the entire vaccine series. Strategic options may include doubling the dose per injection and even increasing the number of doses to 4 doses, so it will become 0,126 instead of 0,16. So how about managing patients with hepatitis B if they have HIV? So here in brief are some principles of treatment. Of course, start the appropriate ART regardless of CD4 count. The ART regimen that you use should act against both viruses, so both HIV and Hep B. And a tenofovir-based regimen is the recommended therapy, meaning we give tenolamivudine, so usually 2 active agents against Hep B, tenofovir, emtricitabine. Emtricitabine is also active against Hep B, together with a third drug. And usually this is efavirenz, and this is to prevent the selection of HIV-resistant mutants. Patients on treatment for Hep B and HIV should receive treatment indefinitely, so don't stop. How do we monitor the Hep B response to treatment? Ideally, we should check Hep B DNA every 3 to 6 months. Primary non-response is if your DNA does not decrease by 10 or 1 log in 3 months or 12 weeks. A complete virologic response is if you achieve undetectable or negative hepatitis B DNA by PCR in 6 to 12 months. While a partial virologic response is if your viral load decreases by 10-fold but is still detectable by 6 months. Another considered virologic response, remember I said if you're E antigen positive, that's an indication of higher viral load, is if the patient loses HBeAg. That may indicate that their DNA is dropping. Other markers that indicate treatment success is if you get improvement in liver fibrosis. There are some tests for this. If your liver enzymes, your SGPT, ALT decreases as a response to treatment kasi nagde-decrease yung liver inflammation. And in those, like I said, they lose their HBeAg if they're baseline E antigen positive and develop anti-HBe. However, this is what other patients ask, the sustained loss of S antigen is rare. It's the chances of which are less than 1% per year. So what's the goals? Hashtag goals for HIV HBV co-infection. To get 10-fold drop in your DNA after 3 months, to get complete suppression of DNA undetectable by 1 year of treatment. Because if your patient doesn't achieve your goals, you need to reassess. First, check if they are compliant to their medication and check for resistance. If your patient does not achieve the goal and he is not cirrhotic and no resistance is directed, you can at least, these patients may be slow responders, and the hope is to reach the goal within 5 years of treatment. However, if your patient is cirrhotic, meaning their liver disease is worse and no resistance is detected, but your suppression is inadequate, there's the option to add entecavir, another first-line Hep B drug, to your tenofovir. How about Hep C? So this briefly shows to us the prevalence of Hep C in focus populations. But this is also from the same study of Dr. Ong and others. It showed that Hep C is present in the Philippines in a significant number, but not as significant as hepatitis B. And the estimated prevalence is about 0.58%, representing about 614,000 infections in the general population. So fortunately, the genotype that's more common in the Philippines is genotype 1 and 2, and this is good because these are the easier to treat genotypes. So the genotype is the subtype of Hep C. So how do we get Hep C? Similar to hepatitis B, it's also a bloodstream infection, but maybe most pertinent is in the population we're discussing is Hep C is commonly transmitted through sharing needles, syringes, and other injection drug use equipment. If also, if patients, we get a lot of these patients, those who receive blood transfusion or organ transplant before the year 1992, receiving dialysis, those who use tattoo or piercing equipment with non-sterile instruments, and less commonly, we may get it through sharing sharp personal items contaminated by blood, having sexual contact with a person who has Hep C, and this may be increased when the sexual practices are higher risk, and being born to a mother who has Hep C, but this is of lower consequence clinically. In short, we check for Hep C if with these risk factors. Maybe the important thing to highlight is we should check Hep C in incarcerated. Those who have unprotected sex with Hep C infected partners, those who use unsafe sexual practices. So how about Hep C transmission in HIV? So heterosexual transmission of Hep C is uncommon, but more likely in those partners who are co-infected with HIV and Hep C. And data suggests that sexual contact is relatively inefficient as a mode of transmission for MSM. However, in HIV-infected MSM, there has been documented multiple outbreaks of acute hepatitis C infection. And this is increased with more creative sexual practices, receptive anal intercourse, use of sex toys, non-injection recreational drug use, chemsex, and concurrent STDs. Maternal to child transmission of Hep C infection occurs in approximately 4 to 7% of patients who are mothers who are Hep C positive to their children. However, if the mother is co-infected with HIV, the chances of transmitting to their child increases to 10 to 20%. So what's the recommended Hep C treatment algorithm? We start with the anti-HCV test. If it's positive, we confirm with the PCR test, the RNA test. And if it's detected, then we link them to care and treatment. So briefly, this again, anti-HCV checks for previous and past past and present exposure to Hep C. Hep C RNA checks current, this is the confirmatory test, current viral carriage of Hep C, while genotype subtypes the patient to what genotype of Hep C they have. So this is relevant if you are going to use Hep C regimens that choose genotypes. So as a review, before we proceed to Hep C treatment, for screening in patients with Hep B, we use HBsAg, while in patients with Hep C, we screen anti-HCV. So the confirmatory test is HCV RNA, and while the viral carriage test, when you test viral load for Hep B, it's HBV DNA, because HBV is a DNA virus. So what's the natural history of someone with hepatitis C? When you have acute hepatitis C, some patients between 20 to 45% spontaneously clear the virus, while 55 to 80% will have chronic or prolonged lifelong infection. The older you are, the higher the chance that you will get a chronic infection. And it's important because patients who have chronic infection, 20% of them will be cirrhotic in 2 decades, while after 40 years, half of these patients have cirrhosis. And once you have cirrhosis, the risk of liver cancer increases. So how do we manage Hep C? So this is a circular from the DOH. With regards to Hep C treatment, we'll go to that. Hep C treatment in people living with HIV. All PL-HIV shall be screened with anti-HCV test. If they're positive, RNA testing is used to confirm current infection. If negative, it's advised that you repeat screening anti-HCV every year for those with ongoing risk, so high risk for infection. For patients with decompensated cirrhosis, meaning they have ascites, jaundice, child score B or C, they should be co-managed with the liver specialist. So refer these patients to tertiary care. So given the limited selection of ARVs locally, for genotype 1456, we can give sofosbuvir ledipasvir. So that's Harvoni. And sofosbuvir daclatasvir for genotype 2 and 3. However, there is no, at the moment, there's no more sofosbuvir ledipasvir in the Philippines. So what we use as a pan-genotypic regimen, sof and sofosbuvir velpatasvir, I'll discuss later, is eligible for all genotypes. There are just some caveats in terms of drug-drug interactions. So in PL-HIV without cirrhosis, the pan-genotypic regimen used is sofosbuvir with daclatasvir once daily. It's a tablet for 12 weeks. If your patient has cirrhosis, you have to extend treatment to 24 weeks. And this is the importance of knowing when to recognize cirrhosis. Hep C treatment may be given with ART, but you should consider drug interaction. So if you recall yung binigay ni Dr. Kate, the Liverpool app can also be used. They also have a site to check drug interaction between hepatitis regimens and HIV treatment regimens. So if you're giving efavirenz, you can't just use daclatasvir 60 milligram. You will have to increase to 90 milligrams per day. So, and to check if your patient is cured, you do the Sustained Virologic Response 12 check, or SVR12. You check for a Hep C RNA 12 weeks after the end of treatment, because an undetectable RNA 12 weeks at the end of after the end of treatment is equivalent to cure. If this is detectable, this may mean treatment failure and you need to refer to a specialist. So again, special mention for drug-to-drug interactions in this context. Daclatasvir needs dose adjustment. So if you're giving it with ritonavir boosted atazanavir, decrease to 30 milligrams per day. If you're giving it with efavirenz, as I mentioned, increase to 90 milligrams per day, not just 60 milligrams per day. So what about sofosbuvir, velpatasvir? It's likely the treatment hubs will be using this eventually in the future. So it's pan-genotypic. It's effective for all regimens, genotype 1 to 6, but you can't use it with efavirenz, etravirin, or nevirapine. Also, since a lot of our regimens are tenofovir-based, take note that velpatasvir can increase your tenofovir levels, and as much as possible should be avoided in those with eGFR less than 60. And due to limited experience with this drug combination, renal monitoring may be recommended. TAF, or the newer version of tenofovir, which is kidney safer, may be an alternative to TDF when taking cobicistat or ritonavir. So, additional notes, Sof-Vel-Vox or sofosbuvir, velpatasvir, voxilaprevir is an additional drug that can be used as a rescue treatment, but there are also drug interactions. As of now, it's not available in the Philippines yet. So maybe highlight the regimens not recommended for patients with co-infection. ARV interruption should not be done just to allow HCV therapy. It's not recommended. Soft-Vel should not be used with efavirenz, etravirin, and nevirapine. Sofosbuvir-based regimen should not be used with tipranavir. Ribavirin should not be used. So sometimes Hep C physicians use ribavirin instead of prolonging the duration of treatment in patients with cirrhosis. If you end up needing to use ribavirin, halimbawa sa patients na nagtitipid, don't use it with didanosine, stavudine, or zidovudine. And also, it's shortening the treatment for Hep C using Harvoni is not recommended for HIV patients. So what do we do after we cure Hep C? If your patient baseline is cirrhotic or you have diagnosis of cirrhosis before you start Hep C treatment, you don't discharge them. They still have to undergo liver cancer screening with alpha-fetoprotein and ultrasound every 6 months. In high-risk populations, including PLHIVs with existing high-risk behavior, cure does not protect you from reinfection with hepatitis C, and you need an annual Hep C assessment. However, if your patient is already previously anti-HCV positive, you cannot use anti-HCV again. You will need to use Hep C RNA testing annually. So maybe a review. For example, you get a patient that you diagnose with chronic Hep B and Hep C. What do? Start, ask for the history of liver-related symptoms. Did your patient bleed? May evidence ba ng encephalopathy, jaundice, other liver-related risk factors? Do they smoke? Do they drink alcohol? Is there family history of liver cancer or cirrhosis? Assess baseline risk for renal dysfunction because of the drugs you'll be using. So that can be increased in co-infection. So if you have either of the virus, Hep B or Hep C should be screened. Other comorbids, usually mga risk factors for fatty liver, and that's diabetes, cholesterol issues, any drug or toxin-related injury. So alcoholic liver disease also. In the physical exam, you look for jaundice, icteric sclerae, ascites or fluid in the belly, a hepatomegaly or a small hard liver on palpation, splenomegaly, encephalopathy, or asterixis, or what we call liver flaps. If your patient has Hep B, advise them to screen household and family members, especially partners, and counsel regarding contact and transmission precautions. Diagnostics that you should do baseline include kidney testing. Standard, of course, is testing liver enzymes because that's the indication. Yung ALT, AST will indicate liver inflammation if elevated. Yung CBC is important because low platelet count indicates cirrhosis. Liver function, that's with albumin, ProTime, INR, bilirubin. Again, evaluate for co-infection. Also, don't forget to vaccinate for Hep A. And that sometimes majority of adults already have had previous Hep A as a child, so you can check by testing anti-HIV IgG. If your patient is negative, vaccinate them against hepatitis A. So viral status assessment, if it's Hep B, do DNA, E antigen, and anti-HB if possible. What are the non-invasive tests for fibrosis? If you are from a treatment hub in Bataan or Pampanga, most likely you know about the APRI score. It's there's an app for this. You can check also online for a calculator. This is the AST to platelet ratio index. So a score more than 2 indicates cirrhosis. You can do a fibroscan or liver fast to check for cirrhosis. And liver cancer screening is done with ultrasound and alpha-fetoprotein. So this is the APRI score, very easy to do. If the AST, you just do AST divided by the upper limit of normal of the AST with the lab you're using divided by the platelet count times 100. If the value is more than 2, then your patient has cirrhosis. The other tests, so this is the liver fast. If more than 0.75, then for example, this patient is already cirrhotic. F4 is cirrhosis. This is the fibroscan machine. So you may have, patients who have may kaya or nagawa ng fibroscan. This checks for liver fibrosis. If it's more than 12.5, that indicates cirrhosis. So who do we screen for liver cancer? These are the patients you need to screen. Males, the over 40 or 50, if there's family history of liver cancer, all patients with cirrhosis, co-infected patients, and persistent DNA elevation. Last slide, what are the liver healthy lifestyle choices you give your patients? Say no to alcohol, don't do drugs, and that includes over-the-counter medications like pain relievers, herbal and natural therapies because they can harm your liver. You have to advise them to stop smoking, to keep a healthy weight and exercise to avoid fatty liver, get Hep A and B vaccine if not yet immune, and of course, undergo regular checkups as needed. So thank you.